Yeah. So um, I have another case for you, David, again today. And as usual, we start with an opening. So today we have a 55 female with dysphagia and falls. That's the chief complaint.
Okay. Yeah, you see, this is like a game. I don't know, Candy Crush or something. As we go along, I see the cases are becoming more and more difficult. So, dysphagia. Okay. So we have a 55 years old female with dysphagia. Now, I wouldn't say at this point in time that dysphagia is that dysphagia is a complaint that I encounter commonly, because I think it used to be we used to learn more about dysphagia in surgery, and now since surgery, I mean, we left it some years ago. It's not a very common complaint for now, but I'll just try and approach it through thinking and see where it can take us. But so looking at both complaints, we have a 55 years old female with dysphagia as well as falls. So let's start with the dysphagia. I'm sure there is a better way to approach it, but so for now, because I'm still trying to organize my thinking, maybe I can just think about it in terms of uh, local causes in the GIT, especially the esophagus, as well as other causes that could be systemic but with manifestations that lead to dysphagia. Or we could say neurological versus structure. So if I speak of something structured, it could be something like uh, an esophageal tumor that is causing physical obstruction and therefore leading to the dysphagia. So esophageal tumor, especially malignancies, but we have more benign causes, esophageal webs, uh, and also patients with something like Zenker's diverticulum can present with dysphagia. But then we could have neurological causes. Neurological causes, like for example, someone can have dysphagia, uh, as a result of any pathology that is affecting the nervous system. So that could also lead to dysphagia. I think uh, I will be more specific as time goes on, but then just trying to throw in some thinking. We have things like achalasia or esophageal dysmotility disorders in general that could lead to dysphagia. And then the other thing is the patient also presented with falls. Uh, Now, when we talk about falls, the question is, are we talking about falls due to weakness? Weakness that is leading to falls, or are we talking about falls due to syncope? So that's a question that I do not have an answer to yet, and therefore I need more information. I think that will help me be more specific. So more information.
Okay. So we move on to the HPI.
Okay, Joseph, you are muted if
Yeah,
you are speaking.
sure. I can see that. Yeah. So 5 months ago, this patient noticed she was having gradual difficulty with walking at a faster pace compared to her baseline. And she also reports that multiple times when she was walking, she would trip and fall. Later, it became difficult even walking at a normal pace. And activities like rising from a sitting position became more difficult, which necessitated supporting herself with hands when she was standing up. She also reported to have stopped using her squat toilet as it was so difficult to stand without the support. She reports numbness of lower limbs, She also reports low back pain. She denies constipation, difficult urination, fecal urinary incontinence. Her upper limbs are normal and they can perform activities of daily living normally. And then over the past 2 months, she has noticed difficulty swallowing. Swallowing is more difficult with solids than liquids. When she tries to swallow, when she tries to swallow, food keeps rolling in her mouth and not going down. But she denies coughing during swallowing. Um, so swallowed foods doesn't get stuck in the chest. The difficulty in swallowing is non-progressive, and she reports significant weight loss. But she denies muscle pain, double vision, hoarse voice, shortness of breath, tremor, fever, night sweats, headache, and altered alimentation. That's HPI. David?
Yes, can I see the first slide of the HPI?
Okay.
Okay, yeah, so what we see, at least initially, um, is that she noticed. So this is something which is being gradual. It's about it's a 5 month history. So we are talking of some things about acute to chronic, um, and as it seems here is that she basically has limb weakness. Uh, and when we think of weakness, when I think of weakness, the first thing that I try to do is even if someone comes and say they have weakness, what I will need to do is first of all to ensure that I am dealing with true neurological weakness, or if I am dealing with something else that mimics true neurological weakness. So there are important things that I need to distinguish from true neurological weakness. So, for example, someone can just have reduced exercise tolerance uh, due to things like anemia or a chronic illness rather than true neurological weakness. So that is one that I'll try to rule out. And then the next one is limitation of movement due to pain. Another one is stiffness or other things like uh, you have, for example, bradykinesia from Parkinson's or someone with apraxia. So those should be distinguished from true weakness. But as it seems from this presentation here, is that it's pointing us more in the direction of true neurological weakness. See, so the patient trips and falls when she tries to when she is walking, and then uh, she has difficulty in rising from a sitting position and even using a squatting toilet. So what that tells me is that there is proximal muscle weakness here, but I also see a possibility that there are elements of distal muscle weakness. For example, the patient is tripping while walking. So the possibility here is that she could be having foot drop, for example, and therefore, as she walks, she cannot clear the ground properly, and that leads to falling. So at this point in time, I'm more biased toward true neurological weakness, and the weakness seems to be predominantly proximal, but I'm still entertaining a possibility that there is a distal weakness. And then, can I see the next slide?
Okay.
Okay, so there are also some sensory symptoms. She reports numbness of the lower limbs. She reports low back pain. Uh, and then there are no autonomic symptoms. She doesn't have autonomic symptoms. and then the upper limbs are completely spared. Okay, can I see the next slide? Okay, and then we come to the dysphagia now. So uh, the weakness that we are talking about, I said predominantly proximal, but most likely we also have an element of distal weakness, and then associated with sensory symptoms, which is numbness. So the since we are talking of true neurological weakness, the pathology here could be anywhere. So we are talking about the central nervous system, that is the brain and spinal cord. We are talking about the anterior horn cells, the motor neurons, the neuromuscular junction, as well as the muscle. So the pathology of the lesion could be anywhere in those areas that I've mentioned. And we see that the patient also has some has some sensory symptoms like numbness of the lower limbs, and then she has low back pain. So since the upper limbs are spared, we could be biased to the idea that this is probably something at the level of the spinal cord downwards. But then we see something else, that the patient is also presenting with dysphagia. So uh, so there is a possibility that the dysphagia that we are talking about is also neurological in nature, or at least it's related to a neurological problem. So uh, we could be dealing with a pathology that is either it's one pathology that is affecting multiple areas at the same time, but then we do not see them anatomically connected. For example, the lower limb weakness that the patient has and the dysphagia with the upper limbs that are completely normal. So it could be a multifocal problem, but I think exam will also help us clarify. But at this point in time, I'm thinking we are dealing with a true neurological weakness. The lesion could be anywhere in those areas that I mentioned. And this dysphagia that we are talking about probably is related to the weakness that we see, or they could be completely different pathologies. But then as we go along, I think I'll be able to clarify what's going on.
Okay. So, yeah. So we continue with a review of other system. Not much here. I reviewed the CVS. There's no palpitation, no chest pain, no external dyspnea, and no orthopnea or PND. Past medical, past surgical history, nothing significant. She is not on any meds. Family social history, her parents were deceased in old age, cause of death unknown. She has a sister who has hypertension. She has three sons who have no known illnesses. She takes alcohol in moderation and she doesn't use illicit drugs. We can discuss anything there. Or,
Okay, so nothing much that helps me make progress. Yes, because we see the past medical as well as past surgical history, uh, also medication history, they're all uneventful. So she's a patient who we could say she was apparently well until she started presenting with these symptoms.
sure.
Yeah, so nothing much to discuss there. I just wanted if there was any clarification, if I do not remember if you presented it, but then any joint symptoms, any skin symptoms, or anything of that sort.
So joints were nothing about joints. Skin, yes, there is. We'll see on exam. There was,
Okay.
yes, we'll see on exam. I'll tell you later.
Okay.
Yeah. So we move on, eh?
Yes.
Okay. So general exam. She's alert and oriented to time, people, and place. She's a febrile. She's not pale. She doesn't have jaundice. There is no lymphadenopathy. She has bilateral lower limb pitting edema, plus one. So skin exam, she had a rash on the right anterior plantar surface, which I described as a hyperpigmented patch with a small, non-tender ulcerating papule at the center. So she didn't complain about this rash. When I was examining the power and stuff, I saw it and I asked, "What is this?" And she told me she was born with the rash, but the central bump is the new thing. So what you are seeing on the picture is a representation. It's unfortunate, my phone broke down and I lost the picture, but it was something like this, except it had a papule at the center. So the patch was she was born with the patch. Then as the papule is the new thing. Vital signs were unremarkable, and systemic exam examining the neuro system, higher centers were normal. All the cranial nerves, including 9 and 10, were normal. The upper limbs were completely normal. And in the lower limbs, she had no atrophy or fasciculation seen. The power were 4/5 in the hip flexors, hip extensors, hip adductors, and abductors. And it was also 4/5 in knee flexors and extensors, but it was normal in the dorsiflexors and plantar flexors. The deep tendon reflexes were normal at the patella and Achilles. Her tone was normal. The plantar reflex was normally downgoing. There was no sustained clonus. Pain and proprioception were intact. Other systems, CVS, abdomen, respiratory, were normal.
Okay, so can I see starting with the general exam? Okay, with the patch, the hyperpigmented patch, uh, I wouldn't pretend to know what exactly is going on here. I can just think about a few things, but then at this point, I do not think if I see anything that connects or that can help me make sense of what is going on. It's a rash on the right anterior plantar surface, hyperpigmented, and a small non-tender ulcerating papule. It's a papule, an ulcerating papule at the center. Okay. And then the vitals are normal. Now let me see the neuro exam.
Okay, here it is.
Okay, so the higher centers are normal. All cranial nerves are normal. And then upper limbs normal. Okay, then we come to the lower limbs now. There is no atrophy or fasciculations seen. And the presentation has been at least 5 months, right?
Sure.
Yeah, so 5 month presentation, there is no atrophy or fasciculations seen. And then power is 4/5 in 4/5 in predominantly proximal muscles, but normal in distal muscles,
Sure.
in distal muscle groups. And then deep tendon reflexes are normal at the patella as well as the Achilles tendon. So knee and ankle reflexes are normal. Tone is normal. The plantar reflex is downgoing, no sustained clonus, and then sensory exam is normal. So to some extent, I think this can help us localize where the lesion is. So we can't say that this is an upper motor neuron lesion because there is no presentation that suggests an upper motor neuron lesion. So if I have to think slow and maybe help others just remember, because for neuro you have to remember every day. So if this was an upper motor neuron lesion, uh, we would see hypertonia, especially considering the fact that it's been 5 months since the patient started presenting with the symptoms. So we would expect hypertonia, hyperreflexia, we would expect a positive Babinski, and then we would also expect so hypertonia, hyperreflexia with the positive Babinski and probably sustained clonus, but we don't see that. So this is lower motor. Now, if we are talking of lower motor, it's something starting with the motor neuron, and then yes. So and did I say lower motor? No, that's not proper. I shouldn't say this is lower motor. The lesion here is not at the level of the motor neurons. So what I was implying is we are dealing with something from the level of the motor neuron, the neuromuscular junction of the muscle. If it was lower motor, we would expect to see atrophy plus or minus fasciculations, which we do not see here. Because if it's lower motor and the muscles have been denervated for 5 months, we would expect atrophy. So we do not see that one here. Yes, so now we are talking that excluding those other possibilities, that means the lesion is at the level of the neuromuscular junction of the muscle. But then with this presentation, we see it's more proximal than distal. I would be more biased toward the fact, the possibility that the lesion is at the level of the muscle rather than the neuromuscular junction, although that is a possibility. Because if we are talking of the neuromuscular junction, we are talking about myasthenia gravis and Lambert-Eaton myasthenic syndrome. The clinical presentation was not suggestive of something like a muscle weakness, fatigable weakness. It wasn't suggestive of that, or we didn't see it worsening with activity or anything like that. So I think it's most likely, I'm biased toward the lesion being at the level of the muscle. So we are dealing with a myopathy, which is predominantly, yes, a proximal myopathy, a predominantly proximal myopathy. So that's where I am right now based on this neuro examination. So a proximal myopathy, how does it relate to the dysphagia that we see? That's a question that I need to think about. And then how does it connect with the hyperpigmented lesion that we see? So the lesion, uh, I'm not sure what to make of it. So I would say that lesion could be a nevus. Yes, so you are talking of a a benign uh, a benign lesion of melanocytes. So it could be a nevus, it could be anything else. But then the papule that you described, that we have an ulcerating papule. So could that the ulcerating papule that we see, could it be that the patient had a benign lesion and then it transformed into something malignant with ulceration, and then the presentation that we see is a manifestation of that? I'm not sure. I'm just trying to throw in some thoughts. But then what I'm at least certain over this point is that we are dealing with a myopathy that is predominantly a lower limb myopathy. The upper limbs do not seem to be involved, and then it is associated with dysphagia. So that's where I am right now. I still need to think more. So let's just proceed to the other parts, and I'll see what I can make of it.
Okay, that's superb localization ability, my friend. Okay, so we move on, and what we have here is the labs. Um, the white count was 10.7, slightly elevated based on this machine. Predominant neutrophilia of 7.8. Other differentials are normal. He had a normal HB of 11.6. Platelets were normal. The ASR was raised at 42. Creatine BUN was normal. TSH was normal at 2.9. AST, ALT were normal, but the ALP was raised at 277, upper limit of normal being 120. The GGT was normal. Total bilirubin was normal. He was HIV negative. Her sugar was normal 7.1, and urinalysis was also normal. She did OGD, which was normal, no obstruction. And we also did the lumbar x-ray. I don't know if you could see anything here, David.
Okay, maybe just help me with the report. I'm trying to zoom it in, but so maybe if you can just help me with what they reported in the
Yeah,
findings.
so there is nothing significant, by the way. And she also did, this is the lateral view, also nothing significant, except for the osteophytes, which are normal at her age. She also did chest x-ray, which was also reportedly normal. Yeah, we can discuss on those data. Let me take you to the labs.
Okay, let me see. Let me see the slide on the labs. Yeah, so a slight neutrophilia. So you have a leukocytosis with a predominance of neutrophils. So what's more striking to me here is the ESR. This patient has inflammation. This patient is inflamed, and when I think of inflammation, I think of mainly three things. Mainly, there could be more than those, but mainly I think of three things. I think of an infection. I think of an autoimmune disease. I think of a malignancy. So, given this patient's presentation, uh, I believe any of these could be possible. So, for example, if we talk of autoimmune disease, we could be talking about an inflammatory myopathy. So, inflammatory myopathy is like dermatomyositis, but then this patient, the skin lesion that you presented, my picture of dermatomyositis doesn't fit in, meaning with the rash specifically. The proximal presentation, yes, but we didn't hear dermatologic manifestations of dermatomyositis or polymyositis. But then, so those are a possibility. And then another possibility that I could think about is, I mean, a patient presenting with proximal myopathy and then dysphagia with the normal GD. So the OGD is normal. That means the structural causes that I was mentioning, like an esophageal web, an esophageal tumor, or diverticulum, they out to the window. So we are dealing with something, I should say something functional, something more physiologic rather than mechanical. So something like it could just be esophageal dysmotility disorder, which if I try through trial and error to think of autoimmune diseases that can present that way, I know systemic sclerosis or scleroderma to present with esophageal dysmotility, and then the symptoms are predominantly on the skin, but uh, there is a form of systemic sclerosis uh, that it presents with other features. So, for example, the muscle weakness has an overlap with other autoimmune diseases, but with all the skin findings. So that is possible with dermatomyositis and polymyositis, with systemic sclerosis. So these, although the picture doesn't fit very neatly into the presentation of this patient, but I need to think about them because of this inflammation. And then, uh, so apart from the myopathies and the systemic sclerosis that I mentioned, and other overlap syndromes, uh, I'm trying to think if I can think about an infection that can have this presentation. An infection that can present with a predominantly proximal myopathy, and then present with dysphagia, and then the skin lesion that we see. I can't think of any. I know we have in other settings diseases like Lyme's disease, which can present with neuropathy. But I think the neuropathy of Lyme's disease is predominantly sensory more than motor, I believe. And the epidemiology, I'm assuming this patient, of course, you've seen this patient in your practice, so it is in our setting, and I do not think that epidemiologically we have Lyme's as we would expect in a setting like maybe the New England region of the United States. So that's an infection I could think about that can present with some neurological symptoms, but epidemiologically doesn't fit. Then HIV, of course, HIV can cause anything, but then HIV is negative in this patient. So what else? Syphilis. Syphilis is yes, it's also another organism with protein manifestations, but then uh, I mean maybe I believe you could have inquired about the history,
Mhm.
about a history maybe of a chancre in the past, and then I also do not see anything that points me in that direction. So I'm struggling to think about an infection that can present that way. And then malignancies. So the hyperpigmented lesion that we see, as I said earlier, it could be a nevus uh, that has a recent change. So that could be a benign nevus, but then it transformed into a malignancy. So a malignancy of the skin, like malignant melanoma. Now, I haven't read malignant melanoma in detail to see if it can have a paraneoplastic presentation, because if we are talking of a malignancy that has led to a myopathy, that has led to an esophageal dysmotility disorder, that is most likely not a result of a metastasis, but a paraneoplastic presentation. So I'm not sure about this. I'm open to learning about it today. If that's the case, that we have a malignant melanoma that has presented with paraneoplastic, a paraneoplastic syndrome, which includes a myopathy as well as an esophageal dysmotility disorder. So the ESR makes me think of infection, autoimmune, and malignancy. I've discussed a few possibilities, and then let me go to the ALP. So the alkaline phosphatase, the sources of this, I mean, apart from thinking of it as a marker of cholestasis, it can also come from other sources like bone and other areas. So uh, I'm not sure exactly what to make about it at this point, but that could be a signal that leads me somewhere. So that's where I am right now. And then about the OGD being normal, I already discussed that we are not dealing with something structural, so we are talking about most likely uh, an esophageal dysmotility, an esophageal motility disorder. So something like an OGD, I mean, wouldn't uh, give results. So you would need other functional tests that could help you determine what's going on. And then what imaging was completely normal. So the back,
Mm.
I talked about the possibility that because she presented with limb weakness, it could be something structural at the level of the spine, but then the localization is telling us the lesion is at the level of the muscle, and therefore we are not thinking of something structural in the spine. And the radiographs were completely normal. Chest radiograph is normal. Yeah, so those are my thoughts at this point. Do we have any other details?
Okay, so maybe yeah, that's a superb discussion, David. Maybe before we proceed, see few colleagues joined later. Maybe you can summarize where we are so that we can go along with them.
Okay. So Joseph has been presenting a case of a 55 years old female with an unremarkable past medical history, who presented with a 5-month history of weakness, weakness especially in the lower limbs. So initially she was experiencing, I should say, reduced exercise tolerance with tripping and falling when she was trying to walk. She's having difficulty in rising from a sitting position, as well as using a squatting toilet. And she later on she presented with dysphagia, which is more to solid foods than liquids. So that was on the part of the HPA. Coming to examination, she had a hyperpigmented patch on the right anterior plantar area with the central papule that was ulcerated. And so apart from that, general examination and vitals were normal. But then coming to neuro exam, the patient had uh, normal muscle bulk, normal tone, normal deep tendon reflexes, but with slightly reduced power in the proximal muscle groups of the lower limbs, 4/5, but the distal muscles, the dorsi, as well as plantar flexors, where flexors and extensors were 5/5. So basically, they are features of a proximal myopathy. I, or I should say, I concluded it to be features of a predominantly proximal myopathy involving the lower limbs, sparing the upper limbs. And then higher centers as well as cranial nerves were completely normal. And here are the labs with slight neutrophilia, a raised ESR, as well as ALP. Other findings were normal, OGD normal, and then radiographs of the spine as well as the chest were normal.
Sure. Yeah, that's the best summary. Yeah, so let's move on and see if we have anything else. And yeah, maybe David, you have to connect now where you are so that we can have a final diagnosis if there is connection between these things, or what do you think?
Okay, so this is where I'm supposed to give a final diagnosis. I do not think I have a final diagnosis,
Sure, you have.
but let me take a few minutes to just try and brainstorm. So as I say, this patient is inflamed. So if I can give a bet, I'll say our final diagnosis is one of the three buckets that I mentioned: an infection, which I struggled to get an infection. So I'm open to learning an infection which can present this way today. So I could take that low on my list because I struggled to get an infection that can explain this. But then I'm struggling to also make to also prioritize between the two remaining buckets that I talked about: autoimmune disease and malignancy. Because for autoimmune disease, as I said, uh, systemic sclerosis without skin manifestations can present with esophageal dysmotility disorder, as well as the muscle symptoms that we see. And then uh, a myopathy, an inflammatory myopathy in this case. An inflammatory myopathy in this case, like dermatomyositis and polymyositis, we do not see typical skin manifestations of those, but then they could be a possibility. And then leaving those, the last one now, which which I am not sure of because I do not have the details. This patient has a skin lesion which has been there almost since birth, a hyperpigmented patch, and then recently it ulcerated and has an ulcerated papule. So I'm thinking, could this be a malignant transformation? That is, we have a malignant melanoma. Now the question is, does a malignant melanoma present with paraneoplastic syndromes like a myopathy and an esophageal dysmotility disorder? I'm not sure. So those are the possibilities that I'm thinking of. I cannot commit to any one of those. So I think I should just sit back and learn from you, Joseph, what was going on here.
Yeah, that's very nice. So I think you have all the information, and yeah, the localization, um, which is the most important thing here, is perfect. That you are seeing symmetrical proximal weakness, and yes, one thing you should think of myopathy. Yes, that's what also I that's what I did also. But and then you are also right. When I saw the rash, I thought like you, this was a benign congenital nevus, for example, that she was born with. But you know, these things have a likelihood of transforming into malignancy, and I thought that was happened. Like you, I diagnosed polymyositis because of symmetrical proximal myopathy, and I thought of the lesion to be a malignant melanoma. But then I wanted to do tests to this patient, and then what she said is I shouldn't do much because she has relatives abroad. She'll go abroad and get treatment, but she needs something to help her. So what I did, because I had this diagnosis, I started her on pure prednisone, 6 milligram with plans to taper, treating that polymyositis. So after some time, the dysphagia resolved, but the weakness persisted. And as I told you, she requested to seek care elsewhere abroad. When she went there, I communicated with the family. She did skin biopsy and muscle biopsy there, and the final diagnosis was the same, that she had malignant melanoma, which had metastated to the bone, and polymyositis. So this also, when I hear this story, I remember the ALP, and as you correctly said, one of the source of ALP is the bones. Yes, was because she had Mets. So some things, David, you decided to just leave them, which is very good because she reported numbness, and as you know, there is no numbness in myopathy. But we see patients with numbness every day, and maybe we don't even get the answer why. So maybe this was one of it. And then on top of that, she had another disease. So I have some few learning points to you. So correctly, when we see symmetrical proximal muscle weakness, we should think of myopathy unless proven otherwise. And when we talk about the idiopathic inflammatory myopathies, we mean things like polymyositis, as in this patient, dermatomyositis, as David, you correctly said, you don't see the markers of dermatomyositis, the Gottron papules and stuff. And then you have inclusion body myositis or immune mediated necrotizing myositis, and lastly, antisynthetase syndrome. So once, David, one thing that you're missing in your approach here is that once you diagnose idiopathic inflammatory myopathy, the next step is to screen for malignancy. Luckily, in this patient, the malignancy presented itself. So yes, you don't even need to screen. It was there, the malignant melanoma. And the dysphagia of this patient is part of the myopathy. Upper esophagus and the oropharynx, they also consist of skeletal muscles, so they can be affected in idiopathic inflammatory myopathies. 36% of people with myositis, they have dysphagia. And when this happens, they have a higher rates of malignancy as in these patients. The pathophysiology for dysphagia in myositis includes reduced pharyngeal contractility, cricopharyngeal dysfunction, reduced laryngeal elevation, and also fragile hypermotility. So yes, the treatment is to give steroids as I did, and disease modifying anti-rheumatic drugs, things like azathioprine, methotrexate, MMF, and also treat the malignancy. But one thing, inflammatory idiopathic myopathies, which are associated with malignancy, they respond poorly to treatment, as you see in this patient. I've seen patients with polymyositis, I give them steroid, and after some time they walk. But this, they couldn't walk. Maybe, I don't know, I've not followed up on the outcome. They said she was about to start a treatment for the cancer and the myositis, but I haven't heard from her. Yeah, so David, I think that's a superb localization first of all, and you were on point. You are doing what I was doing. You just lacked on the connecting the two, but yeah, that was very nice.
Wow. Okay. So is it time for reflections from my side?
Sure.
Okay. Well, this was an incredible journey. I mean, it was nerve wracking for me. But then, as always, I think maybe as I said, as we keep doing these sessions, the cases keep on getting harder and harder. But one thing I'm learning is I shouldn't stop hypothesizing.
Sure.
Sometimes because like I said, I was considering the possibility of malignant melanoma, but then the question was, can it have a presentation like this? I mean, it's not something I've come across before. So I just had to throw in a hypothesis, and then turns out to be true. So I should just say my mind is blown away, and I'm blushing at the same time, and we should just keep learning. I mean, medicine never ceases to amaze me. So uh, this was this was a great case, and I think I have identified a lot of gaps that I need to go and cover. So thank you very much for the case.
You're welcome.
Uh, yeah, so it's a very good day today. I mean, we have so many people, and I should say I'm very humbled that uh, from the humble beginnings a few months ago, the platform is becoming bigger and bigger. So to a point that we have some senior colleagues joining us. This is very encouraging. So I saw some I saw some texts popping up from Dr. Hanifa, from Dr. Evans, and others. So at this point, I should just welcome anyone who have anything to share. I mean, concerning the case, if they had different thinking, anything that you'd like to share at this point. Karibuni sana.
Or any question?
Yes. So anything, any question, any comment, uh, any other diagnostic possibilities that you would need to add to the thinking. Karibuni.
Yes, Alex.
Alex, karibu.
Thank you, David and Joseph. Thank you, Joseph, for your non-stop uh, nice case seeking behavior. It makes this platform very nice, man. When you were explaining this case, I was also carried away with the myopathies. When we were uh, during our MD period, Actually, I did a presentation during those neurology classes. When you were rotating neurology, you were given this to present case reports and sometimes journals. So I presented on myopathy. So when you were presenting, I was totally carried away with myopathy. Then I said, this is myopathy. I can't be forgetting it. And the raising ALP, I said, this is part also. Some of them may have elevated ALP in myopathy.
Mhm.
But I thank you. The learning point to me today, which really, as David said, that medicine never stops to amaze me. The point that uh, in every myopathy, especially idiopathic inflammatory myopathy, you should try to seek for malignancy. So that is have been cemented in my head now. I won't forget it. So if I meet a patient with inflammatory myopathies, I have to be keen on that because that was a new learning point to me today. To admit that I didn't think it because the lesion was like popping up and going away, popping up to me, and then I just wanted to ignore it, but I said no. Why this lesion has changed from a normal one now to ulceration? Something is happening there. And then, like David, how he was wondering whether the malignant could be there. And I was trying to think melanoma. I was trying to think those neuroendocrine tumors with uh, the stories of Anthony Lambert. I couldn't see it fitting well. So I like that idea that we should be thinking of malignancy when we see idiopathic inflammatory myopathy. That
Sure.
is really awakening thing for us who practice in day to day and see patients. But also, another thing is that I would like to congratulate you, Joseph, for your attention. You paid attention to that lesion. Someone would be carried away that to hear. This was there from death
Mhm.
and you know everything happening there, but you paid special attention to it. And it turned out to be our diagnosis actually started there, and all
Mm.
the problems are arising because of that malignancy. So, congratulations for you both once again. I would like to encourage you to continue this hard-working behavior of seeking for nice cases. It helps us a lot to learn and keep us fresh uh, and give us new knowledges and new ways of thinking. Sometimes you might have read them, but because of not meeting something like that, you might forget. But in a platform like this one, they awaken the mindset and the brain and start thinking about it again. So thank you guys. I really appreciate your input. David, once again, you win always. Congratulations.
Thank you, Alex.
Thank you, Alex. So for anyone who hasn't listened from David from where we started, you could we'll post this on YouTube on the AfroDX channel, and you can see that.
Joseph, can you, because I think it's I'm becoming a BBC. Okay, I've seen it. So there is a question here.
Mm.
How do I get the schedule? So uh, karibu sana daktari. So what we do is mostly we do this on Sundays. So we share the links before the day of the session. So yes, sometimes we do change the schedules depending on convenience, but mostly we do them on Sundays, starting 8 p.m. But sometimes it's mostly on weekends. If it's not on Sunday, it's on Saturday. So, but we share the links early on. So just make sure to keep in touch with whoever shared the link today, uh, and we'll keep sharing through all platforms. So maybe if you can just if you feel free to unmute and tell us from uh, where you got the link from, so we can make sure that we use that channel always to make sure that the link reaches you and you join. We are very happy to see you here.
Okay, hello everyone.
Hello, Irene.
I got hi. I'm a second year resident, so I got this link in our class WhatsApp group, and unfortunately, the one who shared the link did not even join the meeting. So,
No,
but it was a great. I wish to be joining every time I get chance.
karibu sana daktari.
Oh, thank you very much. So, a second year resident in which institution?
Oh, in QHAS, which is in Mwanza, Tanzania.
Oh, thank you very much for joining. We'll make sure
Thank
that
you.
the link reaches you every single time. So I think we have a good link there. We have Dr. Juliet Nkwabi,
Mkwabi,
who is
Mkwabi is
practicing at
there.
Bugando. So yeah,
Oh
so we'll
yeah,
make sure that whenever we are sharing the link in our group, we insist on her to make sure that it reaches you.
thank
And
you.
then yeah, and feel free to share with other colleagues so they can join and we learn together. I mean, we need to learn from others.
Yeah, yeah,
That's what
that's true.
all this is about. Karibu sana.
A-
Asante.
And maybe one day we expect unknown cases from you guys from Kuhas.
Yeah, that's sure.
David will crush them all.
Okay.
And everyone, I should tell everyone you haven't heard Joseph. I mean, the day Joseph discusses a case, that will be a landslide. You will see. I promise.
I see Mook is a
Muki,
hand.
Muki, I see you have a hand. Karibu.
Okay, Dr. Joseph, thank you very much for this presentation. I know you discuss about melanoma. It's a difficult and challenging case, especially in dermatology, because these are the typical presentations when we're talking to the melanoma. So usually do not adhere to the classification that we use. That the size might be different, the border irregularity, and the diameter. So to diagnose a melanoma, you need to, it's very difficult. And there's a lot of a differential diagnosis, like David said, benign, there's a subaortic keratosis, a lot. And also there's an issue of in situ melanoma, which are confirmed to epidermis. That are the challenge also to diagnose. But I need to add, in your investigations, yes, you did a biopsy, but in when we are talking to the blood test, I think the LDH, lactate dehydrogenase, was a very important to this patient. This indicating an increased disease burden as well as a prognostic factors. So I think so that's my comment on concern to the cases to this case.
Thank you very much, Muki, our
But
very own dermatologist. Thank
another
you for the.
issue, metastatic. So melanoma is it's very hard to think to metastasize to the gastrointestinal. That's what that you are supposed to do. That you do is taking biopsy. So taking biopsy was a great thing that Dr. Davis do to this patient. So thank you very much, guys.
Thank you.
Asante sana Muki. And we had another question from Dr. Uras about the YouTube channel. So it's AfroDX. I've typed in the message in the chat. So everyone who is not sure of the spelling, you can just go in there and check. Again, very happy to see some senior colleagues here. And if you do not mind, please unmute yourself and just say hi to the group in here. Dr. Urasa, if you are still around, karibu usalimie umati.
I think maybe he's in a place where she cannot unmute.
Yeah, possibly.
Dr. Joseph,
Yeah, I'm okay.
Yes, Muki, karibu.
so what way forward to this person concern the treatment of the melanoma?
Yeah, so as I told you, I so she she went abroad. She has family abroad. So what I did is to follow up on the diagnosis, but they said she was about to start treatment. I was told what, what treatment, and maybe I will follow up later. And she's still
Thank you.
yeah.
Okay, do we have anything else from anyone? Anything? Oh, so sorry, Dr. Uras, about the technical issues. He's trying to unmute, but then he hasn't succeeded. But we are very happy to see you here, and we'll keep sending these links so we can have more and more people joining us, and we hope to learn from you too. Karibuni sana. Okay, Dr. Zal has said hi at the beginning. Dr. Zal, has some people hadn't joined before. Do you mind saying hi again?
Hello, everyone.
Hello.
Did you put me in the group of the senior colleagues? Because I don't believe I'm senior. So, but this was an interesting case. And I really enjoyed the session. And it was mind twisting, and I was really following up. And yeah, yeah, thank you very much.
Karibu.
Asante sana daktari for joining us. Thank you, Dr. Uras. I see a message there. I hope everyone can see. Thanks and congrats for setting up this educative forum. We are very encouraged by those encouraging words, and we are very happy that you joined us, and we hope to learn from you in the future. So let's keep pushing together and share the knowledge. And then Kiara, karibu usalimie. I've seen your text. Karibu tusalimie if you're in a place where you can unmute and just say hi.
Hello, all.
Hello, Kiara.
Hello.
Hi, Kiara.
Thank you all. Sorry I came in late, but I got the final diagnosis and just wanted to say thank you for the enlightenment, and I'll be catching up on the YouTube link. So thank you once again for the very nice, interesting last few minutes of the presentation.
Oh, and then we have thank you very much, Kiara. Then we have Professor Munseri. We are very happy to see you here today, Prof. Can you just unmute and say hi to the group? If you're in a place where you
Yeah,
can.
hi. I was just looking for the unmute button. Hi, everyone. And I think I popped in very serendipitously. I happened to just see this link in a place that I don't usually visit. Being a Sunday, today I said, okay, let me just look what's happening. And I found that this might be very interesting, the way how it was introduced. So it was in the Physician Association group. And so I said, okay, let me just see what Dr. David is going to discuss. So, yeah, I think I got it towards the end, but really interesting and thought provoking. And I'm really looking forward to listening to many more of these. I think it's a very interesting and very important forum for physicians. Yeah, so thank you for. I'm even not sure how long this has been going on, but it's very educative, and I would encourage even our residents to perhaps take part in such forum. I think it's very, very educative. Thank you.
Thank you very much, Prof. We are speechless. I mean, this coming from you, I think it's very encouraging for us, and
Yeah.
we'll do our level best to keep this up, and hoping to learn from you too.
Oh, definitely. So, how long has this been going on?
Well, so with I mean a big audience like this, me and Joseph, I think it's been several months now. We started just the two of us. I think that was in Joseph. When was it? I
Early
think
January.
yeah, we started in February. So Joseph was presenting cases to me. So it was just the two of us in Google Meets, and then we opened it to our class, that is the class of 2022,
Mm-hmm.
and then we introduced it to residents. So I think we've done about 6 cases so far with the residents.
Okay, okay. I
Yeah,
guess many physicians would really be interested. It goes just more beyond the residents because they are very unique and peculiar cases that really would be challenging to clinicians because what the mind does not know, the eyes will never see, you know. And when
Sure.
others do it, then you say, "Oh, I remember this case, and this was how it was discussed."
Sure.
So
yeah,
thank you so
sure.
much. Yeah.
Thank you very much for hoping to see you around in the coming ones, and we'll keep
Definitely,
sharing the
definitely,
links.
absolutely. I think I'll be a big member of this of this group. Very educational.
Thank you very much, Prof.
Thank you.
Okay, so Joseph,
Yeah.
I think I do not see any other hands, so it's been a big day. I mean, I think Joseph and I have been dreaming of this
Sure.
for a long time, and I see the dream is coming true. So we will keep sharing the link, and we encourage everyone to share the link widely. We wish to see everyone here who is interested, so we'll keep sharing the link. And thank you everyone for joining. Especially Prof. Munseri, I should say thank you very much because I know your schedule is really tight right now, many miles away, but you are still able to join us. So we are happy to see you and happy to see many other colleagues from different settings. I saw Dr. Hanifa here, I saw Dr. David Urasa, Dr. Zalha, and then we had residents from Kuhas. We have the frequenters here, the class of 2022, residents from Muhas, and then I saw some colleagues from Kairuki University. So I think the forum is growing bigger and bigger every day. Thank you everyone for joining. Hoping to see you next weekend. Have a good night, everyone.
Good night.
Well done.